So a lot of the treatments are common, right? So this is not one of those diseases where that the treatment is so different, right? So I think I would screen because somehow it will get attention and they'll get treated. So so I think that's one answer. The second is, for optimal results, you need a conducive environment. So yes, so I think I would do everything. Now, primary prevention and the things that we've talked about, obesity, and they will take a long time to show results, right? You need everything. But the soda tax that we talked about, it will have a downstream effect, but it will have it in the next generation. But we also have people who have CKD. So this is the wrong, I'm going to say wrong approach, because this is what the UN high level says, that we've talked about, we have hypertension, we have diabetes, and that should be enough, right? Because eventually it'll, but how about the so many people? We've done the systematic review of the number of people with CKD. There are about 400 million people with CKD3 or worse, right, globally. So what about those people? Right, so they need to be treated. You cannot ignore. What about people who need dialysis? So I think this is the debate that and even when you have these kinds of policies, there are still people who will develop CKD, and they need to be treated. So you need both.
Thank you, Tassim. Don't leave. One more question.
Thank you, Dr. Japar. Great talk. I'm Aminu Bello from University of Alberta. So obviously, from your presentation for public health intervention to reduce CKD progression and adverse related outcomes will require easy access to affordable diagnostic tools in primary care. For CKD risk identification, monitoring and management. Currently, about 10 to 20% of countries in low and middle income countries do not have access to easy diagnosis tool like serum creatinine, ability to measure serum creatinine, report and estimate the EGFR, ability to measure protein, quantify it, which for identification as well as monitoring for risk of progression. What do you have to say? How can countries improve access to these facilities through provision of point-of-care diagnosis tools? Is that feasible? What is the way forward?
Yeah, I think that's a good point. I think, accessibility, so I think we have to, for proteinuria screening is easy. You can do dipstick proteinuria screening, right? So I think dipsticks are, so I think that's, so for areas and for rural remote areas, I think we are advocating using, and that's what we are doing in a lot of our trials in the rural remote communities. And I think for EGFR screening, what we have done, at least from our own experience, is we have not had terrible challenges. Maybe there are some very, very remote areas where you don't have labs, but I think there are always mechanisms available. We do want to, there are efforts at developing point-of-care testing for EGFR, for serum creatinine, and I think those efforts need to, we need to make more effort, greater efforts for point-of-care testing for EGFR. Sure, yeah.
Thank you, Tassim. So our last speaker is Dr. Laura Solá. She is a key opinion leader in Uruguay, and Uruguay has been an example for us in Latin America in order of organization. So this is the best organized country in Latin America, and they have been an example for us in terms of having registries for CKD and ESRD and how these registries impact outcomes. Thanks, Dr. Solá.
Well, thank you very much for the organizing committee for the privilege of sharing this session with these chairs and other speakers. And I will refer to national registries to control to CKD. We all know that registries are very important. A birth and death registry were the first that gave you important information regarding demographic and epidemiologic data, life expectancy, and then burden of disease. But when we want to know more regarding disease, incidence, prevalence, you have to go to the disease registries. Cancer registries began to be published in the late 40s, and ESRD dialysis registries began in the 70s, first as national registries, then as regional. And as you know, ESRD registries does not only show what is the true prevalence of the disease, as has been shown by the Global Atlas and others, the registry show mostly about access to treatment. And this has been shown that high-income countries have much higher prevalence of ESRD-treated patients than low-income countries. So the gaps in access have been studied by other registries like the European Registry that has shown in their continent to have various incidence and prevalence of ESRD patients that could not be explained only because of life expectancy or by GDP. So they wonder if there will be other potential causes of these differences in the renal replacement therapy incidence or prevalence. That will be very worrying to have overuse or denial to access to renal replacement therapy, but also concerning to have different incidence or progression of CKD, because our public health system fails to prevent the development of CKD, or the healthcare system structure or access results in a suboptimal CKD care. So you need information for previous stages from CKD patients. There are different kinds of data, electronic medical record-based CKD registries that used to be said that could handle mostly hard endpoints as death or budget, but it had been shown by Canada Health Service, by Brenda, that it could also be used for other information too. Service as NANAS, as it's shown very delightful table with the risk categories, have shown in a cross-sectional way what could be the prevalence of CKD along the population. But if you need results regarding outcomes, you need longitudinal data. So you can have longitudinal data, as has been shown by Professor, regarding CKD prognosis consortium, and lots of data have been shown of all-cause mortality, cardiovascular mortality, and end-stage renal disease across different races could be similar, for instance. More recently, an international network of chronic kidney disease cohort studies supported by the ISN had been launched, and it includes prospective cohort studies and also 2 registries from Uruguay and from Australia. In this Congress, some of the results of these studies have been shown, and in 2 different studies of CKD progression and hypertension. And if you look to both studies, the baseline characteristics of registries are some way different from the cohort studies. So the results regarding outcomes also differ between the different studies regarding ESRD and death. Now we'll come to our National Renal Healthcare Program registry. The registry is part of a prevention program launched in Uruguay in 2004, of which I have spoken on the Global CKD Policy Forum on Friday. It includes many other strategies that include education for GDPs, screening, but we will refer only to this registry. It is a voluntary registry of nephrologists that in these 12 years have included almost 10,000 patients, mostly male, 60% male, and 65% elderly population. So it's not surprising that the primary causes of disease are hypertension, vascular, and diabetic disease. Patients are referred mostly by the primary care physicians at early stages of the disease, and only 20% of the patients were referred with CKD stages 4 or 5. CKD registry has been a very useful tool for evaluating progression rates, but also quality of care. Regarding quality of care at the primary care level, we have several goals that patients should be referred in early stages, comparing when we began in 2005 with the last 3 years. We see that mostly is the same. Almost 80% of the patients have early referral. Patients with RAS blockage and other groups that have almost 100% of the patients with blockage. So there's a great heterogeneity even regarding nephrology care. Good news is, I don't know what Andrew say, Courage say, but patients before being delivered to nephrologists, if we have almost 2,000 patients, and when we have data of what was the glomerular filtration lost before being delivered, it was almost 2.5 milliliters per year. The same patients, when they were under nephrology care, they lost only 0.6 milliliters per minute. I think that's good news. Other way to see the same thing is that there are some patients that were lost to follow-up. And comparing patients under nephrology control with those that were follow-up, there was a significant reduction of death and the composite endpoint of death and ESRD of almost 40%. We have looked at CKD and death risk factors. This is what we have shown in the Uruguayan Congress several years ago regarding a population of advanced CKD patients, stage 4 and over, that were almost 1,000 patients follow-up for a median of a year and a half. And the risk factors were mostly traditional risk factors for what we considered high glomerular filtration loss, systolic blood pressure, proteinuria, and diabetic nephropathy. And ESRD in this population was a little bit higher rate than mortality, and the risk factors were almost the same, being protective, older age, and renin-angiotensin system blockage. Regarding mortality, besides male gender, age, and proteinuria having a higher risk for mortality, patients follow up in those advanced CKD clinics with multidisciplinary team have a lower mortality. There are other CKD progression risk factors. So Gadola and our team have looked at it and published in a Uruguayan journal that acidosis increases with the CKD stage, and considering acidosis when bicarbonate levels are less than 23, And those patients that had acidosis have a higher increase on their creatinine levels than those who never had acidosis, or they have one-time acidosis and after there was corrected. Regarding cardiovascular comorbidity, is very prevalent in our population. CKD patients increase the cardiovascular comorbidity at increasing CKD stages. So we have looked at the risk factors for new cardiovascular events in this population. As it expected, previous comorbidity increases the risk, as well as diabetes, older age, male, gender, and proteinuria. And systolic blood pressure, as many times, has a U-shaped risk regarding new cardiovascular events with higher risk at low and higher levels, but with glomerular filtration rate being protective. So it's not surprising that new cardiovascular events increase their risk with increasing CKD stages. In the same direction, mortality risk increases its risk according to CKD stages, and this also have been published by many other authors, including the annual data report of the renal data system. In this Congress, we have recently shown in a poster, we wanted to look if there were any differences regarding the effect of angiotensin-converting enzyme inhibitors versus receptor blockers regarding end-stage renal disease or survival. And we looked only on a little number of patients, less than 2,000, that weren't having these drugs when they began the follow-up. And what we saw is that ESRD risk was significantly higher in the not treated group comparing with the treated group, but no difference were found regarding both treatments. There was no, with a competing risk regression analysis, censored by death and adjusted for a lot of variables. When we looked to survival, we couldn't see any significant differences. But we should also take in consideration that what we do in previous stages of CKD also have an impact on patients when they get into dialysis. And we have seen, we have shown in the last Latin American Congress that risk factors for the first-year mortality of patients, one on dialysis, are related. Of course, of the patients having a fistula or a graft, but also there's a 30% reduction of the risk if those patients were followed up for more than 1 year by nephrologist. So our closing remarks should be that we could achieve a long time a better quality of primary care level with better achievement of therapeutic goals, improvement of quality of care under nephrologist follow-up. Even we have shown that remarkable heterogeneity is still present. There's a reduction in CKD progression and mortality, and perhaps that's why when they have shown the Health Atlas, Uruguayans have a lower CKD mortality rate, perhaps, under nephrologist control. Improvement of quality of care at dialysis initiation is still needed. There are still lots of patients that initiate dialysis without a permanent access. And comparisons between registries and cohorts may improve the knowledge of CKD progression and death risk. We have shown the work of our Renal Healthcare Committee, and with the help of more than 100 nephrologists that work in our renal healthcare program.
Thank you, Dr. Sola. Are there any questions from the audience? We have a couple of extra minutes, and I wondered if you might describe for us how your registry works. Is it voluntary reporting by the nephrologists, and how often are they asked to report?
Yes. It's a voluntary registry of nephrologists that work in healthcare providers that sign an agreement, the institution, with the National Fund of Resources, that is the institution that pays for dialysis. So there's a formal agreement between a public institution that pays for dialysis, the National Fund of Resources, and the health providers. Nephrologists of those centers should include patients if they have glomerular filtration rate less than 60, they have proteinuria or albuminuria less than 300 if they are diabetics. There is a web-based registry with an initial form and a control form that should be filled every 6 months. And we evaluate every year we have a meeting with all the groups where we evaluate results of all the groups, not saying who is worse and who is better, but just looking at giving them what they are, their results, and the rest anonymous.
Thank you, Ken. Very impressive results. I'm actually, I want to congratulate you because, this is hard, right? Like 100 nephrologists volunteering, reporting, and you're so well organized. And, well, that does not happen in other countries in Latin America. As I said, you are our example. So you have a very high rate of nephrologists per million population. And, for us, we are in the lower end. So we would need at least twice the amount of nephrologists in order to be able to provide nephrology care to all patients with CKD stages. So do you think this care could be delivered by general practitioners? And, what is your opinion on this?
I think that perhaps we have 47 nephrologists per million population, one of the highest rates in the world. We have other things that are needed to have a healthcare program. We have universal coverage for drugs. So as you asked Dr. Jafar, if you screen a patient, you have to give him ACE inhibitors, statins, if they're hypertensive or they are dyslipidemic, you have to give them hypoglycemic drugs. If they are diabetic, that we have a universal coverage for health. We also have a universal coverage for dialysis. So that is the setting, the setting in which our program is held. I think some patients can be followed up by general practitioners, CKD patients stages 3A mostly, aged patients, so perhaps you don't need to have registry of all the patients, only the ones that are in risk to progress, so that will take less effort. There's an initiative in Chile of having networks of TICS technology, that having consultations from apart sites, so you can consult a nephrologist, and then the nephrologist can get the data and include it in that registry. Also having records of clinical care will help to have a registry if the provider, health provider, send it to you.
Well, thank you. If there's no more questions for the audience, we would conclude the session at this time. Thanks.
And be sure to attend the plenary starting in about 15 minutes.
Thank you. Very impressive stuff, right?
Very impressive.
Yeah. They're like, well, they have 47 nephrologists per million.
Yeah.
And we have 9. So.
Well, universal coverage, you can make it the condition.
Yes.
Thank you, Ariella.
Thank you so much.
Then you can make it the condition of coverage that you fill out forms.
Exactly.